Bolted.
Yeah.
No, even more. No, the other way. Totally the other way. Keep going, keep going, keep going. A little more, a little more. There you go. Now it's I was like sliding off.
You fell off the earth.
Yeah.
Go live. It's everywhere.
Excellent. We are now live everywhere. Hello, everybody. Good evening. I am Dr. Rahi Victory. Welcome to Fertility Factor Fiction. And I am your host. I am a double board certified reproductive endocrinology and infertility specialist, licensed both in Canada and the US, and hopefully, if they ever answer me, the UK very soon. Still working on that one, but we hopefully will have that all sorted out very soon. Along with efforts to establish a UK clinic very soon as well. So, welcome to everybody that's jumping on. We got a cool show tonight for you. Tonight, we are going to review an article about the relationship between your age and the number of eggs you can expect. And then next time we're back, which may be next week, we're not sure. I'll be on holidays, but we might try and pull it off. We're going to do one on the number of euploid embryos you need. And that way you can figure out the relationship between number of eggs you'll have, number of embryos you need. So we're going to probably call that one Embryo Math 2.0. If you have not watched our Embryo Math video, definitely check it out. It is very helpful in determining how many cycles you will need. And there's definitely a lot of misinformation out there. So this will clarify things for you.
Questions are pouring in.
Are they already?
Already.
Oh boy.
Just so you know.
Big, huge message to everyone. And that is that I wanted to thank everyone for all the amazing comments on the anniversary post I put out. Thank you for that. Very special day for Wendy and I. It's actually our anniversary tomorrow, but we celebrated on Friday evening by going to Chicago and meeting Jonathan Tettleman, who's this amazing opera singer. And what a nice guy, super cool guy. So I don't think he'll be watching our show, but if you are, thank you for a lovely evening. Your voice is spectacular. And thank you to everyone who mentioned that Wendy looked amazing in that dress. She definitely looked amazing in that dress. So thank you for that. Also, to all those of you who are waiting for us to implement our new hyperoxygenation protocol, it is a work in progress. Please stop calling the office asking when it's going to happen. We don't know yet. We have a meeting with the guy who is the world expert in maturing eggs on July 15th. And we will know exactly how we are progressing with that program once we've spoken to him. I also probably need to buy a hyperbaric oxygen chamber so that we can treat people here.
It's great. The hyperbaric.
Oh yeah. Tia's tried the hyperbaric oxygen chamber. Yeah.
For
Except
anything.
you said you were choking to death initially.
Bad instructions. Bad instructions. Poor translation.
Translation.
Yeah, I was choking.
But once
100%.
you put on the oxygen mask, you said you were instantly fine.
Yeah, until that moment, I was I think borderline death.
Yeah.
Borderline almost died.
But then you were fine. Instantly.
I'm like Hercules. I can do anything.
There you go. So we are going to have a protocol for you, and I will arrange things, and we will have a package like we always do, but it's not ready yet. So please don't call in asking because we don't have it yet. So that's where we're at with everything here at VRC. Our other two clinics should be opening any minute. I will find a minute to talk to Lisa, and then I can manage that. And I am finally taking a much needed week off because they are killing me this week at work, trying to catch up on everything before I take a week off. So that's where we're at. And Tarek just told me that he's headed off to Egypt soon. So
August.
yeah, sometime in August, he's going to the homeland. Very cool. Very cool. Mervet's been before.
She claims she was when she was a kid. Everybody wants to go to Egypt, but we're going.
Like really going.
We're going.
Right.
Absolutely.
Yeah.
Taking all the
camels to the pyramids, the whole
really?
thing. Wow.
We're going to pretend we're not Egyptian, so we can actually experience non-Egyptian Egypt.
Really?
Yeah.
That's cool. That sounds really fun. You guys still have family and stuff there.
Yeah. I saw a lot of them moved to Canada, oddly enough. I don't know what's going on there. So it's kind of like during the summertime, a lot of people are going.
Yeah.
So it just happened to be, hey, let's go.
Okay, now I don't know anything
Go
about
ahead.
Egypt, but like, why would you go to Egypt in the summertime? Isn't it like scorching hot there?
It's really a kid's schedule.
It's a kid's
It's a
schedule, but
kid's schedule.
it is.
Yeah. Oh yeah. Oh yeah. Like I wanted to go down south to Luxor on a Swan, where they have all the like the temples and all this ancient Egypt
Yeah, yeah,
propaganda
yeah,
stuff.
yeah.
Nobody is telling me to go. Everyone's like, you're not allowed to go.
It's,
It's way too hot. It's
it's
50
way too.
degrees out there. You're gonna die. You're gonna melt. You can't go.
You're gonna.
What am I gonna do? He's like, the most you can go is on the Mediterranean or the Red Sea. You can do the beach thing. I mean, I got beaches here. Our beaches are better.
Our
Obviously.
beaches are
You know,
better.
I'm dealing
Right,
with that right
right.
now.
Yeah,
Our beaches are better.
yeah.
But tourism's kind of like 50-50.
Wow, wow.
I got museums, I got pyramids, but if I want to go deep ancient Egypt, like where the movies are,
Scorching.
scorching.
Oh wow. All right. Cool. Well, that's Tarek. That's me.
Yeah.
So yeah, very different trips. I'm going to my cottage. He's going to Egypt. Okay. So tonight's topic, you can share.
Okay.
Are we already sharing?
No, not yet.
Oh, I
I'll
thought
share
it.
right now for you.
Oh, but I'm
Yeah,
sharing.
you're
Yeah,
sharing.
yeah,
Yeah.
Okay. So tonight's topic, journal pre-proof, hasn't been published yet, from RBMO, one of my favorites. I love this journal. It's great. They have good science in there. So this study is called An Age-Related Nomogram for Antral Follicle Counts as a Reference Guide for Reproductive Decision Making, an observational study of 7,573 women. Huge. Lots of women that they put into this study. So this is from London, England, and a couple of different centers there, the reproductive medicine unit at University College, and also the gynecology ultrasound center and the Harley Street Clinic. Harley Street is this famous street in London, England, where they have all of the high-end fertility places. I am not planning to open my clinic there. It's way too expensive, but super cool. And they did a lot of people in this. So they wanted to basically see what the relationship was between age and the number of eggs that you could expect. So they just took the ultrasounds from all these women and they analyzed them by age and then broke it down and did some statistical analysis. And this would be a quick one because it's like a reference guide for you guys, but we will come out with a separate video like Embryo Math 2.0 to explain to people based on this new updated data what to expect and you know what to think of when you're going through this. So they took all their patients from 2017 to 2022. Could COVID have had an impact on this data? Maybe, who knows? Hard to tease out, although 3 years of it had nothing to do with COVID, so hopefully not a huge issue. They didn't analyze that. So they looked at 8,821 data entries from 7,573 women. Big data set, massive. They estimated the relationship between AFC and age to get a nomogram, and then they broke it down into different centiles. So the less than the 10th percentile, 25th, 50th, which would be your median, 75th, and then the 90th centile for each patient and age group. And then they created the nomograms for it. And then they also looked at people who had either been on birth control before, or they also looked at, well, I should say, or they looked at women who had previously had a cyst removed. So really helpful data so that you can kind of guide your decision-making process. Okay, so ovarian reserve tests, obviously we look at AMH, we look at FSH, we look at antral follicle counts. Those are the big ones. There used to be some older tests we did called the Clomid challenge test, where you would give someone Clomid and see how high their estrogen would go, but then we realized that's kind of a useless test, expensive, complicated, and no one does that anymore that I'm aware of. So these days we're really looking very much at antral follicle count, AMH, and FSH. Even the FSH is not particularly useful anymore unless it's really elevated, in which case you know that you're in a bit of trouble. But the AMH is fairly predictive, and certainly the antral follicle count is quite predictive. So this has been shown in lots of studies, and these guys wanted to see, well, can we offer people some advice? Can we tell them if you're 30, you should expect this many, if you're 20, you should expect this many? And keep in mind, the ranges are huge, right? So I'll go through that all with you. Okay, so materials and methods, you should be able to see it here. Maybe I should turn it this way, eh? And then people and make it big. Is that better? Does that look better, or is it better the other way?
Put it back the other way just to see, because I'm
How's that?
okay.
Which way?
That the way you have it right now.
Okay, so I'll leave it the way it is. Okay, so they looked at the records from all those scans, 1st of January 2017 and 22nd of September 2022. I don't know what the significance of those dates were, but whatever. So they did it at a gynecologic ultrasound center, which is a specialist ultrasound unit in London. They excluded 9,013 duplicate ultrasound encounters. I don't know how they got that. And 20,648 ultrasound encounters with no antral follicle count record. So there was a huge amount of exclusion. You always need to factor in, where are these patients coming from? Who are they? How did they get included? Was this a selected population? So, like, over double the number, almost triple the number of people in the actual study were excluded because of the fact that they didn't have the data that they needed. So it could have skewed things a little bit. And then they took out people, which is quite funny, who had previously had their ovaries removed, which I don't know how they were in there for an AFC, but whatever. That one was a little puzzling for me.
Very controlled experiment.
A very controlled experiment, yeah. Okay, so then they looked at how they did it. So they go through this whole explanation of timing, and that there are multiple studies showing that your AFC between even day 2 to 5 is a reasonable assessment. We usually do day 2 to 4, but 2 to 5 is perfectly fine. So they said, okay, let's look at what the numbers are from day 2 to 5, and then they looked at all of that and assessed it based on that. They had 6 different ultrasound sonographers, and they were counting everything that was between 2 and 10 millimeters. So that's what they were looking for. And then they go through the whole process. They used a really fancy ultrasound machine called the Voluson E10. The Voluson E10 is part of the Expert series from GE. It's one step below the ones that we use, but it's still a very good ultrasound. We use the E20s. They're fabulous. So that's the top of the line for what's available right now. And ultrasound quality does make a difference in what you do. Okay, so let's go through the actual data, because that's the important part. Okay, so here's the beginning. 2017 to 2022, 38,484. They excluded duplicate entries. That was 9,000 worth. I have no idea how that happens. So they got rid of those. Then they had 29,000. From the 29,000, 20,648 didn't have any AFC recorded, so they excluded those. They had 8,823. 2 of them apparently had a previous oophorectomy. I don't know how you do an antral follicle count on someone that had both their ovaries removed, but whatever. So they were excluded. And then the remainder was 8,821 from 7,573 patients. So obviously some of those patients, about 1,300's worth, ended up going back for more than one scan. And so they included those as well. Okay. They then excluded patients who were less than 18 and over 55. So they were down to, they reduced it by 123. So then they created the nomogram based on that. And super cool, they actually looked at follicular and luteal phase, because you all know that we do duostims now. And so they actually looked at both of those. So that's also really, really helpful. So 4,256 were patients that had done encounters, and that was in the nomogram. Then they had some that had previously been on hormones, so that was an additional 566, and then another 534 with a previous cyst, 2,039 in the follicular phase, and 1,068 in the luteal phase. Okay, so what did they find? So here is your first graph. I'll blow that up so you guys can see it. So this is follicle count, including patients that were on hormonal contraceptives. So these are people that had previously taken some kind of birth control, whether it was progesterone only or combined birth control. It didn't matter. They had them both in there, and ages again between 18 to 55. So in the less than 10th percentile, you're looking at somewhere around 21 to 25 eggs if you're past 21. Now, keep in mind, if you look at the initial curves for all of these, when you're very young, you actually have a little bit less eggs that are retrieved. And that's why we don't love using young egg donors. They actually produce poor quality eggs and fewer eggs. So that sweet spot is really a little bit past your like 20. So 20, 21, then you're starting to get more eggs, better quality eggs as well. So the lowest numbers in that young age group, at like the less than 10th percentile, you're looking at on the low end producing, just hang up on that dude. On the low end, you're looking at producing somewhere around 21 follicles. As you get older, so let's say you look at 30, so if I draw a line for you here, let's just make this nice and sharp and we'll do it in red. So if you look at the 30 mark, which is roughly about there, so now as you go through that whole line right there, you can see that you've got on the low end down to about 14, 13. When you get to the 25th percentile, you're back up close to the 20s. You get up into the 50th percentile, you're over 25. So the average at 30 is still making a large number of eggs. And then the really high producers are making very, very high levels. When you get up to 35, which is, oops, here, so you're seeing another decline, right? So less than 10th percentile, 35, they're making less than 10 eggs. They're making about 5 eggs if they've previously been on birth control. In the 25th percentile, which is the second green line there, you can see, so that one you're looking more like around the 10 to 15 number. In the median, which is like the average, you're getting around 20, which is actually really impressive because we don't traditionally get 20 eggs on average from a 35-year-old. So again, I'm not sure how completely valid this data set is, but it's impressive that they got that in theirs. Move up to 38, you're really starting to get a little more hampered, and your numbers are starting to decline. You get to 40, look at the 10th percentile, you're looking at 4 or 5 eggs. So those who are in the lower ovarian reserve category are really going to be in trouble when they're in their 40s, but you're still able to get somewhere around 10 to 15 eggs if you're in the middle of the range at the age of 40. By the time you're moving out to sort of 43, which is another landmark for us, over here, you're again seeing very, very low numbers. So at 43, the less than 10th percentile, you're making 1 or 2 eggs. Even the 25th percentile, you're looking at 4 or 5. The 50th percentile max, you're looking at about 10. And it's a rare number that goes over that. And even in the highest category, you're up around the 15 to 20 mark, which is very, very rare. So they next decided to look at this from the standpoint of patients that were, oh, that was not what I wanted to do. Sorry, guys. They wanted to look at this from the standpoint of patients that were not on necessarily hormone contraception. And they actually compared the two results between the hormone patients and the non-hormone patients. And they basically showed that the results are very similar. And they got basically the exact same results. So there's no difference between the patients that had birth control versus no birth control. So they got the exact same results out of it. Then they examined the results between follicular and luteal phase. And you can see here that the follicular phase in general was actually a tiny bit higher than the luteal phase. So the purple lines are luteal. The follicular phase is the orangey colored line, but they're basically very, very similar. I mean, we're talking about a couple of eggs difference. So very young patients made way more eggs. Again, if you're looking at this in terms of breakdown, when you're in, let's say, the 30 range, you're looking at high numbers. By the time you're getting to 35, you're dropping off considerably. 40s, you're looking at way lower numbers, and this is the overall average. and the number of encounters that they had. So very different numbers when you look at it in this way. So the next one was looking at down here, the preectomy group, and in that previous cystectomy group, what they wanted to show was that the numbers are much, much lower. So you can see very clearly in this bottom graph that you got a lot less if you had previously had a cyst. So the women in their 20s were up in the 30 range for the average in the 50th percentile when we looked at the previous slide. But in this group, you're down to about 15 to 20. So almost half the number of eggs if you've previously had a cystectomy. The problem with cystectomies, and I've said this on many shows, is it entirely depends on who's doing the surgery and how they're doing it. If they just rip off half the ovary and start burning the ovary and they do a lot of damage to the ovary, yes, of course, it's going to do a lot of harm. You're going to get fewer eggs. But if people do a proper cystectomy, nothing's going to happen. So last week, on Wednesday, I had a patient that had a dermoid in each ovary. We very carefully opened the ovary. We made a tiny little incision. We super gently peeled the ovary off of the cyst, pulled it all off, never used the cautery to burn anything so that there wasn't any damage to the ovary. And then we were able to go ahead and remove the cyst intact, actually, so there was no damage. And she did great. That patient should not expect any significant decline in her ovarian reserve because we didn't damage the ovary in any way. You do have to damage it in order for it to cause the ovarian reserve to go down. And typically that's either bipolar, excessive pulling and tugging, failure to hydrate the ovary properly because dry tissue is not helpful. And when you put in dry carbon dioxide, it does, to blow up the belly, it does kind of dry out the tissue. So you do need to be careful. We need to keep the tissues healthy and blood flowing and so on. But it's not difficult to do. And if you're a good surgeon, it's very possible. So end result, we know that patients that have cysts have way fewer follicles. You got to watch out for that. It's not always a great idea to do a cystectomy before your egg retrieval, but sometimes it's necessary for sure, especially with endometriomas, because they can get easily infected if you puncture them. We know that patients who are in the average ranges are actually going to do quite well, but patients that are in the lower ranges are very subject to their age. So this is just the foundation for what we're going to use to then help patients understand what they need to anticipate in terms of the number of embryos they're going to need in order to get pregnant, and euploid embryos, and how many embryos you need to find euploid embryos. And then we can kind of backpedal it and say, okay, the average patient at this age should expect this many eggs. So we're going to talk averages. And then that patient would expect this many embryos to form. And from that many embryos at this age, you would expect this many to be genetically normal. And we know what the results are from the number of genetically normal embryos you need. So stay tuned for that. That will be coming up on an upcoming show where we will explain to you that relationship. And then we can put it all together in a special video and you guys can watch that online. So it'll be coming to you soon. So not really a fact or fiction, but some information that's valuable for you all to know. Okay, cool. That's it for that one. We will come back.
Ready?
I'm ready.
Hello, dear.
We're not sharing anymore.
No, you're not.
Okay.
Hello, dear Dr. Victor and dear Tari.
Oh, very nice.
Is it okay to get spray tan/tan lotion?
No.
When you are
don't even ask the rest of that. No, don't put any chemicals on you, and spray tan is horrible for you anyways. So no, you want a tan, go lie out in the sun. That's how you get a tan. Yeah.
Much love from Kitzbühel.
Kitzbühel? Oh, I know who that is. Yeah. Hi, Jana.
First egg retrieval yielded 6 eggs, but 0 blasts.
Oh, sorry.
I have endo, so was then prescribed Lupron Depot plus letrozole for 2 months and started stims. After 7 days, I had one follicle, estrogen less than 30, so cycle canceled.
Yeah.
Do you think my ovaries are going to respond ever again? If so, when? And how often should I be monitored? They said call when second period comes.
So Lupron and letrozole prior to an IVF cycle are useless. They're helpful prior to FET, but they're not helpful prior to your stim. In fact, if anything, they're going to suppress you. So I've never done that before, and I never would. You can try Vizan. That's been shown to be helpful. Rapamycin has been shown to be helpful, which is sirolimus or tacrolimus. And there are other treatments you can attempt, but I would never try Lupron and letrozole prior to stim. For stim, if you need to make more eggs, there are things that can boost your egg production. PRP might be helpful, although you got to be very careful in an endo patient that you're not poking into the cyst. You could definitely try something like doing testosterone supplementation. You can do human growth hormone supplementation. All of those can be super useful for you to stimulate the ovaries to produce more eggs. DHEA can also be helpful. Lots of supplements. At the end of the day, you're probably going to need 1 to 2 months for your ovaries to go back to normal. Do I think they'll ever respond again? They should. But I mean, you're probably in a tough situation because they already got eggs from you and it didn't yield a good result. So I'm really sorry about that, but that is going to be egg quality related, sperm quality related, and you do need quite a few when you've got bad endo to make it work. You know, it is a bloody miracle. I have not gone blind from that light.
Right.
It is very bright. Yeah. The car is making me lose my hearing and the light is killing me too. Yeah.
Hi, my favorite Dr. V and Dr. T.
Okay. You love the doctor.
I love that.
I know.
Yeah.
I know you do.
Two-part question.
Okay. Two-parter. Oh,
Part one.
okay.
My lads increase minimally after 2 lits.
Sure.
We are asked to do paternal and donor lit. If we do just donor and skip paternal, will that be better? That's part one.
Better, it won't be better. I mean, better would probably be to do both, but you don't have to, and you could get away with just donor, and that should be fine. We usually do 2, maximum 3, and if that's not working, we go to donor. Having said that, Dr. Kwok Kim, who's the the director of the program at Rosalind Franklin University on reproductive immunology, believes that you need multiple rounds of lit to get a response. So, I mean, sometimes you need a lot. Yeah.
Part two.
2.
I am on Lupron and letrozole since 4 months now for endo.
Okay.
As I have to do more lits, can I start Vizan right now or wait a few days while I continue with next lit? I want to avoid Lupron.
Yeah. I mean, Vizan has been shown to be beneficial prior to a stim. I haven't looked up data on prior to an FET, but it is usable before a stim. So there's nothing wrong with that.
What progesterone levels for a medicated transfer are acceptable? My prog was 12 without PIL shot and suppositories, but dropped to 8 before an early miscarriage. Did low prog cause miscarriage?
If you're talking about nanograms per milliliter, that is low. So you want a minimum of 10 to 30 if you don't have endo, much higher if you do have endo. Could it have caused a miscarriage? I mean, the number one cause of miscarriage is genetic abnormality, but is it possible that it's related to that? Yes, of course it's possible. Yeah.
How long after COVID should you wait to do an IVF retrieval?
2 months.
Hi, Dr. V. Mickey turned 2 months today. Thanks again for our little miracle.
Oh, that's so cute. Congratulations. That's awesome. I love it.
In a modified natural cycle, if I trigger and ovulate early, like the next day, will it affect my transfer 7 days after trigger HCG?
No.
Thyroid 0.43 MIU over L. Is this too low?
0.43?
Yeah.
It's bordering on too low, but it's not technically too low yet.
Hi, Dr. V. Can you start Omnitrope at day 7?
There's various studies on Omnitrope. I've seen them start as early as 2 months before the stim, and I've seen people start 2 weeks before the stim. I've seen another study where they started it with stim. No one knows for sure what the best protocol is. We do 2 weeks before because that just makes sense to me, but no one knows what the right answer is. So 4 days before is fine. Are we doing TikTok too?
Mm-hmm.
Yeah. Okay. I wasn't sure.
What can a hysteroscopy show?
Fibroids, polyps, misshapen uterus. If you're really good as a hysteroscopist, you might be able to detect some of the features of endometritis, micropolyps, lots of blood vessels, atypical vessels, things like that. But generally speaking, it's structural defects. So either something wrong with the shape of the uterus or a polyp or a fibroid.
Low count motility and morphology. Is IVF our only option?
No, you can always try IUI or try improving the sperm. Whether or not it'll work is a different question, but it is more difficult the lower the count, the lower the motility, the lower the morphology for sure.
Have you been watching the effects of the... Let me grab my screen here. So it's a picture of the shot on fertility.
I don't know what the shot is.
Yeah, I guess you won't. Yeah, I guess you don't. It's a shot. It's a syringe. Syringe emoji.
I don't know.
Just any syringe you want.
Any syringe.
Any syringe you want.
I don't
Talk
know.
about the effects of any random syringe on fertility. On to the next question. Does a high FSH and LH indicate PCOS?
No, a high FSH indicates that you are likely getting into a situation where your ovaries are weak. So anything over 12, you have to worry about your ovarian reserve. A high LH could either be representative of PCOS or it could be representative of weak ovaries as well. So LH is less telling, but high FSH is related to weak ovaries.
When do you think ultrasound will be safer?
What? Ultrasound's safe all the time.
There you go. That's the answer. We're going with that.
You know, years ago, there was this crazy Instagram person that said, like, she's one of these all natural people that went wild because they, you know, all you have to say is, I lick tree bark, and like people start worshiping you, right?
Yeah.
It's so stupid.
I actually licked tree bark before. Nothing happened.
Another
Thought I should put that out there. Nothing happened.
couple of
They
speakers,
promised me a lot of
a
things.
lot of things. Yeah, no. So,
Near retired.
yeah. So bottom line is that that does not at all, you know, help anybody, right? And so, yeah, I don't think that that stuff makes a ton of sense.
Never does. I'm against all that.
Yeah, I made fun of this woman who said she was one of these tree bark licking people, and she said basically ultrasounds are terrible for you. I was like, what the hell are you talking about? Zero evidence that ultrasounds. So I presented a scientific study, and they just kick you out. Like they can't handle anyone disagreeing with what they believe.
Because you're part of the system.
Yeah.
You're part of the system. You're indoctrinated.
Yeah. There was another post from a lady the other day that said, you know, polygamy and having multiple partners is like the best thing ever, and that's the natural way human beings should be. I'm like, that's the dumbest thing I've ever heard. Like, what are you talking about? There's no evidence to support the idea that people should just randomly have sex with all sorts of people.
You should really put that out there right now.
I am. I'm saying that right now.
Ask also what they think.
Yeah. Do you guys all think that they should have, like, that people should just have a random number of partners and love as many people as you want to love at the same time? I mean, I hope you don't, because we're going to have a big argument if you do. But yeah, so I said, this is dumb. And then they called me a bigot.
You're a bigot.
I'm a bigot. How am I a bigot? Because I believe people should be faithful to one another.
Hell no, somebody says. I wonder how many, you know, put it out there again for the people just dropping out. I think it's a great question.
Like, how are you a bigot? That's the thing that kills me. Like, that's everyone's thing these days, right? If you comment on anything, they want to attack you if you try and say that their position is scientifically incorrect. God help you if you have evidence. Then they like flame you. Then they're just like angry people.
A lot of emojis.
A lot of emojis.
A lot of emojis coming out in that conversation.
Yeah, a lot. All right, next question. My tea is finally warming up.
Here we go.
It's good, yeah.
Warm it up.
Yeah.
What is new?
All right.
Really? So that was the thing you stumbled upon?
Yeah, she's like, there's this woman that posted saying like the natural human norm is to have like, you know, multiple sexual partners. I was like, what? Like, no.
Interesting.
Everybody was asking me how I stayed married for so long. I met one woman. I married her. Only one I've ever been with. Proud to say that. Nothing to compare it to. Love her to bits. She's a great woman. Worth every minute of it.
You're a great man.
There you go. Thank you.
How many donor eggs do you recommend purchasing, assuming no sperm issue and age of donor is 28? Thank you so much.
So the problem with, I'm not a huge fan of frozen donor eggs. I mean, it works in certain circumstances and we'll probably look into it in the future. But at the moment, you get way more bang for your buck by getting a fresh donor if you're doing it in Canada. So I'm not a huge fan of buying donor eggs. If you're in the US, it's a different story because some of the insurance companies pay for it. So if they're going to pay for frozen eggs, you need a lot, like a lot. 28-year-old, let's say you get 8 eggs because they usually come in batches of 8, right? So you buy 8 eggs. So if you're lucky, 6 of them will fertilize, if you're lucky. From the 6, probably 3 will become blastocysts, maybe 4, okay, if you're really lucky. And then 30% are going to be abnormal, so you're going to have 1 or 2 normal embryos. If you look at the research from Richard Scott's group, you need somewhere between 3 to 5 genetically normal embryos to get a pregnancy. Maybe not that many if she's 28, so let's say 2 to 4, 2 to 3. So you're still kind of short 1 embryo, possibly. So you need a lot of eggs, a lot when they're frozen. It's so like way different when they're fresh.
3 batches of 8?
Well, 2 for sure.
2 for sure, right?
2 for sure. Yeah.
2 for sure.
You need a lot.
I didn't know that.
Yeah. There you go.
There you go.
Another lesson for Tark. Today's lesson for Tark.
Yeah. The bark was also new.
The tree bark.
Yeah. That was me too. Can you explain the process of doing donor lit?
Get blood from someone that you trust, who you implicitly trust. We have to sexually disease screen them. And then assuming that they're good, we process their blood and then we do the lit. We inject it into you. So it just has to be someone you are comfortable exposing yourself to because it is blood to blood contact.
Maybe this is a dumb question.
Okay. There's no dumb questions.
But why would someone use donor lit?
Because they're not responding to their partners.
Does it have the same benefit if you get it from a donor versus if you get it?
Yeah.
Oh, no matter what, lit will make a difference?
You just need dude antigens. Dude antigens. Yeah.
Gotcha.
Yeah.
Gotcha.
Yeah.
So amongst dudes, it's all the same?
You need XY. These days, we got to be careful. Not dude. You need XY antigens. There you go. Yeah.
That's the concern.
Yeah.
Hi, doctors. Wow, this person is amazing. This is my new best friend.
Yeah.
Yeah. How can I help you?
Yeah.
For a fully natural FET, is suppository progesterone enough? Or is it better to be combined with PIO?
It's always better to have both. No question. Tarek knew that too. Yeah.
I was like, you know what? Yeah. Maybe your Dr. Victor would say, hey, Tarek, why don't you try it? And I'll be like, both it is.
Oh, see, Nicole Pouget said not normal on.
It is not normal.
It's not normal.
It is not normal.
You know, you guys all have to jump on when I post.
When we have these moments, this is the moment.
No, everybody has to get on and, fight back.
Fight back.
Ellie Max, hi, wondering if you sometimes treat both partners for endometritis. Can that help stop it? Yes, Ellie. In fact, I always treat both partners, and that's the only way to try and stop it. Good question, though. Very good question.
It floats your boat, but I don't think it'll work out at all.
Safe answer.
Safe answer.
Yeah.
We got the safe answer.
And let's be honest, what guy is not going to say, I'd love to have sex with more than one woman? Well, I wouldn't. But what other guy would not say, I'd love to have sex with with more than one woman? but it's just not healthy for society. It's not healthy for relationships. Like, how can you have a committed family and then you're sleeping randomly with different people? I don't get that at all. And there's tons of research that shows that that's harmful. So where they're coming off, she's like, there's a book, go read it. You're a bigot. I'm like, a book?
And you're a bigot.
That's like when the people saying that, there's a midwifery book that says it's safe to deliver babies at 42 weeks. And I should go read the book. I'm like, read the book. I can show you 3 randomized controlled trials that clearly demonstrate that that's not true.
Read the book, Doc.
Read the book.
Read the book.
Apparently, I can't read. I don't know.
Dr. V,
Yeah.
happy early anniversary.
Oh, thank you.
Just wondering how, in your experience, bilateral endometriomas impact the output/yield for retrievals.
Less eggs, more immature eggs, a higher rate of genetically abnormal eggs or embryos. So it does significantly impact it, very significantly.
Men don't care, but as a woman, I physically don't want to, I don't want that to mess with my pH or body in any way. And emotionally, most women want monogamy.
Yeah, thank you. I love that. See? Okay, now I don't love the part where you said men don't care. I care. I'm a one woman man and I love
Jenna
it a
just wrote
bit.
out to say hi, Dad.
I love,
Just
yeah.
keep
Hi, Dad. And I love Jenna too. So I guess I'm kind of a three woman guy because I got my mom, my wife, and my daughter.
There you go.
Hi, baby. How are you?
She has no idea what she walked into.
No, she has no idea what she walked into. I love you too, honey.
Hi, Docs. I have 12 eggs retrieved and only 4 mature. Do
Oh.
you like the dual trigger, and which ones do you use?
Well, these days, because Lupron's gone, we use triptorelin and we use HCG. So that's what we use. And dual trigger helps. So would human growth hormone and testosterone. They're all reasonable. Jenna says she's good and she loves me. I saw that fly by. I love you too, baby. Big round of applause for Jenna again, everybody. She got into med school and she starts this September. Very proud of you, honey.
Amazing.
Keep the victory legacy going.
I like that.
Somebody asked what causes high FSH and what can you do to, or no, what's a normal FSH and what can you do to fix weak ovaries? High FSH is anything over 12 generally. That's a pretty accepted standard. And then what can you do to fix it? There isn't a lot. DHEA, testosterone, human growth hormone, PRP are the only things that have ever been shown to have any kind of benefit.
Good evening, Dr. V and the great T.
Oh, the great T. Hey, I like that. Like it's like you're a magician or something. The great
warrior.
Yeah.
I'm taking CoQ10.
Yeah.
Inositol.
Yeah.
NAC. Are they safe to continue if I conceive?
Yes.
Or should I stop?
Yeah. We get this question all the time. Yeah, it's totally safe to keep going. Don't stop your supplements.
Dr. T can what is it? I concur.
You concur.
I concur.
Yeah.
Good evening, Dr. V and T.
Good evening.
Good evening. Of course, we have to warm our manners. FET with letrozole is pending.
Hmm?
RE suggested PIO support post FET Q2-3. Daily and not daily. Rationale corpus luteum secretes progesterone. Do you agree or need daily? Correction Q2, 3 days.
Yeah.
3 days.
Yeah. So there's a study from Shady Grove, which they published in Fertility and Sterility, I think, showing that once every 3 days was sufficient and had the same outcomes. I'm not a huge fan of that approach because I don't like the yo-yo effect it creates in the progesterone. But it is true that with the corpus luteum there, you can overshoot the amount of progesterone. So you do have to titrate very carefully. And it does make a mess of things if you're triggering people and then starting proj, because as the corpus starts to produce progesterone and you're giving progesterone, there does come a point where you overshoot, and that overshoot then can cause problems because then you're kind of on birth control. And then as the corpus starts to fade, you'll start to lose some of the progesterone from that. And so then you got to catch up with your, sort of exogenous or administered progesterone. So we try not to trigger. Generally speaking, but yeah, and our success rates are like the highest we've ever had them. Yep.
Excuse me. I gotta go in here. Hell no to polygamy. Love my wife. Wouldn't trade her for anything. This ish is messed up. Also, do we know when Dr. T will be filling in for you? He needs to come on camera. Talking right to me, man.
Yeah, right there. There you go. Yeah. Yeah. Yeah.
I got a bunch of questions here. Don't worry.
All right. No problem.
Yeah, my favorite Dr. V and Dr. T. Well, this is
You're just living the high life, man. I should have just done social media. I could have gotten
You
my
could have easily
honorary
gotten
doctor's
doctorate.
degree like
Absolutely.
this guy.
I was
Yeah.
telling you this earlier.
Yeah, I could have gone and worked.
Creativity is the challenge.
I could have worked for, Kim Garabedian or Amy. I could have been Amy's.
No, you could do.
I love Amy. Amy's awesome.
Two-part question.
Yeah,
Part one.
yeah.
My lads increase minimally after 2 lits.
Okay.
We are asked to do a paternal and donor lit.
We did that one.
Oh, we did that one.
Yeah.
Sorry.
Yeah, no, it's okay.
Does hysteroscopy before an IVF improve egg quality? Also, could you explain
Whoa,
endometrial?
whoa. What? Does hysteroscopy before an IVF cycle improve egg quality?
That is the first question, sir.
Absolutely nothing to do with one another. Hysteroscopy is a evaluation of the inside of your uterus. You're not even coming close to the ovaries. So there is no relationship between egg quality and hysteroscopy. Part two?
Yeah, I was just reading on TikTok, there's some fanfare.
I see that. They want to see you. Yeah.
Yeah, but
You want us to switch? I can put him in front of the camera. Yeah.
crowd goes wild. Also, could you explain the endometrial immunomodulation? My doc recommends that for RAF. Love you too. Thanks for all you do. XOXO.
Well, immune modulation requires we know what's wrong. So if I know what's wrong with you from testing, I can tell you what medications to take. But without that, you're shooting in the dark, and I don't really advocate for that. I think it's risky. Yeah. Chels, our favorite Chels, has a question.
Charles, welcome back.
Why are HCG ranges so broad? Age has an impact. Embryo quality has an impact. There's a study that came out yesterday or day before yesterday that suggests that the score of the embryo is associated with the HCG level, like the morphological grade of the embryo is associated with your HCG level. So there's all sorts of different factors. No embryo is going to be the same. Yeah. Okay, we got to answer this Diana question. She's asked like 10 times in a row.
Okay.
In fact,
I think that's an intentional effort.
I know. In fact, I think it's like 40 times. I'm 42. I had 10 eggs retrieved, 8 mature, 6 blastocysts, 1 embryo made it abnormal. Was it bad protocol? No, it's just the fact that you're 42. At 42, you are going to end up with a very, very low number of genetically normal embryos. About 80 to 90% of them will be abnormal. Now, I don't understand how you said 6 blastocysts, 1 embryo made it abnormal. I'm not sure what that means. But if you ended up with 8 mature, 6 fertilized, and only 1 made it to blastocyst, that could be a bad lab because you should get more embryos. But you're still going to need multiple cycles to get even 1 or 2 normal embryos.
Hey, Dr. V.
Yeah.
Wife had TR surgery.
TR surgery?
Mm-hmm.
TR surgery. Okay.
Sure.
Okay. Yeah.
Left tube was fixed, but healed, shut. HSU shows block up to ampullary area.
Okay.
Would you do a tubal cannulation to try and open up left tube again?
No.
2 years after surgery?
No. Waste of time. Don't bother. Go for IVF. Get your tubes removed.
Genesis tubal repair? Question mark.
Tubal repair. Yeah. Hi, baby girl. Look at you coming
Tubal
in.
repair surgery. Look at that.
We need to bring Jay on the show.
We told her.
Jay, you ready to come on the show and answer questions, honey?
I told her we should do a duel.
You and Jenna?
Me versus Jenna.
She actually knows some stuff.
I know a lot of stuff.
Oh, she says yes. She'd come on.
She's on, eh?
Yeah. We should bring her on the show. We can't bring you on TikTok, honey. You're on TikTok, but that's okay. Oh, and Nicole says we'd love to see her on.
Yeah, of course. We would love to see Jen on for sure.
Maybe Jen will do it when we're up at the cottage.
There you go.
I can't wait to see you on Friday, honey. Okay, if they suspected they saw endo during ectopic pregnancy, would having a lap to clear that help? You should just treat it when they're in there for the ectopic, but otherwise, yes, you should consider having a lap afterwards.
What is the other test other than Emma and Alice to test the microbiome?
There are many now. The one we use is Fertility, but there are many, and I don't ever push any company. I mean, I do love the folks at Fertility. We're all friends now, so I definitely support them from the standpoint of they provide a good service and the cost is very reasonable, but there are other services that you can use as well. M-Analysis is similar. I don't like their reports as much. There's Locus Medicus, which was the original Fertility, but Fertility is doing a much better job. So yeah, there's different options there.
Got pregnant fast. Oh,
I got to answer this because it's a dude.
Dude.
We never get dude questions.
Let's go with Dave.
David Richard. Hi, Dr. V and Mr. T. How common are two vessel cords and what are risks to having it? There are no known risks other than that it is a higher association with genetically abnormal fetuses, but I've actually never had that happen. They've always been genetically normal. We don't know what causes it. We don't know when to predict it or expect it. And they're pretty common. Like I get one probably every 2 months. Like it's pretty common that we see that. Yeah.
Got pregnant fast, but first one ectopic in March of 2023 and second miscarriage on October of 23.
Okay.
HSG was normal. All labs are normal. My husband's semen test was normal. Been trying since November 2023, but still no results.
And how old is she?
Mystery age. Don't know.
Yeah, I would need to know more details about you. So contact info@drvictory.com. Ask for a consult. We'll figure it out.
Does eating oh, here we go. You've been waiting on this one.
Wait.
Is there fun up here?
Is it ghetto? Okay, this is the wrong terminology. I'm reading. Is it ghetto that my clinic doesn't have a speaker to hear the heartbeat on the ultrasound machine? Yes, it is. Yeah. Oh, no. Okay, I see, Charles. You explain later. So there are people that vehemently believe that power Doppler, which is what you need in order to listen, is bad for the baby and can terminate the pregnancy. So they want you to use M mode, and you can't hear it with M mode. You can only hear it with power Doppler.
What do you do?
I don't do it anymore. The girls do it all.
What
did I do in the past?
Sound or no sound?
I used the power Doppler. I did it with sound.
All I know is I've only heard sound. That's all I ever heard.
But this is dating, very early, like 6-7 weeks. Yeah. So my team, they do power Doppler also. I mean, M mode also.
There you go.
I
got a real good one for you.
Okay, all right, go for it.
Does eating yams?
Okay.
You with me so far?
Mm-hmm.
Or using
yams,
Progresses Plus serum made with progesterone from wild yam.
Yeah.
Help with ovulation, and does it increase chances of ovulating more than one egg?
No, it's going to decrease your chances of ovulating. Progesterone is what we put in birth control, so no, that's not going to help you at all.
What about eating the yams part?
No. You're such a goof. Charlotte, 32-33, 2 egg retrievals, 20 eggs, 17 fertilized. Well done. 17 embryos. Oh my God, 17 embryos. 5 transfers, 3 chemicals. What's happening? You need to talk to me and I'll tell you what's happening. You probably have either an infection or an immunological problem, or they made you a whole bunch of genetically abnormal eggs. Plus, if you made 20 eggs, sometimes it's a lot and that can impact egg quality. But contact us. Yeah.
What is the best standard timing for day 6 3BB donor embryo?
What are the chances for a day 6?
No. What is the best standard timing for day 6 3BB donor embryo?
I don't know what they mean by standard timing.
Maybe
timing of putting in the embryo.
Yeah. Best
we would give you 6 days of progesterone.
What's the cause of a blighted ovum, and how long do I have to wait for my next transfer?
No one knows. Probably poor embryo quality, and you need to wait till you have your next period, and then you're fine.
Oh, here's something serious.
Yeah.
5 miscarriages in 2 years.
Oh, sorry.
Unexplained. Use letrozole, progesterone, prednisone, and Lovenox.
Okay.
Are they any good studies on unexplained recurrent miscarriage and the use of medication support?
Yes, there are data points that show that steroids will help, intralipids will help, heparin and aspirin will help. even randomly, blindly, but you really need targeted assessment and treatment. So those are the cases where we see you, talk to you, do the appropriate testing, figure out what's wrong, and then we treat you so that we're figuring out exactly what you need done and how to do it.
What's the sweet spot for a donor?
From an age standpoint, like 22, 23 to like 32.
The big spot right
Yeah.
there.
Healthy, no major medical problems. Does it feel like it's 800 degrees in here?
I'm warm.
I'm warm too.
I'm warm.
That's weird. Okay.
Can you link the study for us to read offline?
So you have to go to Reproductive Biomedicine Online and then look at articles in press, and it's like half a page down there. So I don't know that I can link it. I probably could link it. I just don't know how to link it.
Send me the link.
Send you the link?
Yeah.
Where will you put it up?
I'll figure it out.
On our Instagram or something?
We'll put something.
All right, sure. Yeah, we'll do that. We can attach it to the.
Who's here from the days
I
where
know.
Dr. Lee did
Right, I used to do.
the scan?
I did. Once upon a time, I used to do all the scans in the morning.
Oh, wow.
Now we do 80.
So you're not doing it anymore?
No.
Yeah.
No. Yeah. Other clinics do, you know.
Really?
Yeah. Yeah. The docs like at Create do their own scans, but then they're 3 hours behind. So
Mhm.
I mean, I love them. Great. I think it's wonderful to have that contact with the patients, but man, that slows you down.
Considering surrogacy now, what would you recommend? Doctors are all stumped. Oh, previous question is, I've had 6 failed transfers with euploid embryos, 42 years old, had lab for endo, downregulated with Lupron and letrozole, worked with an RI even though all normal, also did uterus, everything's okay. Considering surrogacy now, what would you recommend? Doctors are all stumped.
Oh, I mean, I'm still willing to chat with you and see if they missed something, which could be the case. But yeah, I mean, 6 euploid embryo transfers with the assistance of an RI, I'd probably tell you to consider a surrogate as well. Yeah.
Dr. V, I've noticed that after a TI or IUI around ovulation, I get flu-like symptoms for just one day and then symptoms disappear. Is there any scientific explanation for it?
A lot of people complain of that. You're not alone. No scientific explanation we're aware of. So no, I don't have an answer for that part of things.
It was like one of my favorite moments in life.
I know when I did the ultrasound, yeah. Yeah. Once upon a time, my favorite moment when I used to do ultrasounds was we had a very, very funny, very foul-mouthed young lady whose husband was a cop. And he wasn't just any cop, he was a massive, massive human being. One of the biggest guys I've ever seen.
I could probably take them.
Yeah, no. He was literally like 2 of you. Like just
Huge.
this giant bodybuilder guy, like
that's
huge. He was in, a special division and all that. I won't get into details. So we've done their IUI. They came in. I actually did it on Thanksgiving Day because I had to do it in the morning before I went on call. And then they came in 2 weeks later to do the ultrasound. So I pop in the ultrasound and I look at her and I go, how big's your house? And she goes, well, it's like a 3-bedroom. And I said, you're going to need an extra bedroom because they had 2 babies in there. And the guy goes, oh my God, I feel like that. And I was like, man, you cannot fall down because even both of us cannot pick you up. Yeah. Yeah. But great guy, very nice couple. Yeah. Everything went well.
Does having a cyst impact implantation if using IVF?
Depends on what kind of cyst and whether it's active or not. Hormonally active, yes. Endometrioma, yes. Dermoid, I'd be worried about your pregnancy, but no, it doesn't impact the implantation to the best of our knowledge. So it depends on what kind of cyst.
Dr. V, does red light therapy help improve the mitochondrial functions in oocytes? Thank you very much.
Whoa. According to the people that believe in it, maybe. Do I believe in it? No. The data, and I've looked at it, is really wishy-washy. Yeah.
Dr. V, do FIGO3 fibroids, the FIGO3, I read it right? Okay. FIGO3 fibroids need to be removed if they are not distorted the cavity?
Only if they're more than 4 centimeters in size. I love the gimmies. Gimmies are nice.
What are your thoughts on taking metformin prior to retrieval?
Metformin?
Mhm.
Great if it's indicated. If you've got insulin resistance, you should. If you've got PCOS, you definitely should. So there are situations where it's indicated. Yep.
Do you recommend PGT testing in my case? Severe male factor infertility, and I'm 40, undergoing my second IVF stimulation.
Absolutely, yeah.
First one failed.
Yeah. At 40, anything over 35, we now recommend it.
Good evening, Dr. V and the great T.
The great T.
See how my voice.
I know. That was like a show intro or something.
I'm being introduced. I'm being summoned to the hall. The great T is here to read your question.
There you go.
I'm taking CoQ10 and Inositol.
You know, the great T needs a great car. I'm just saying.
I'm
just saying.
Another concern.
Yeah. Okay, I'm taking Inositol.
You're breaking me. You're breaking down here. I'm taking CoQ10 and Inositol NAC.
Yeah.
Are they safe to continue if I
Yes.
conceive?
Yes.
Should I stop at any point?
No, don't stop.
Don't stop. How is endo treated not to get pregnant for just symptoms?
Oh, medical treatments. So progesterone, birth control pill, IUD, Depo-Provera, evil, but it does work. Orilissa, Religulix, Myfembree, great, works really, really well. I'm a fan. Lupron with add-back eventually, or you go down the surgical route where they ablate it, remove it, excise it, whatever the case is.
Okay. Considering PRP after hearing about it in your podcast with Ann Matthews.
Oh, sure, yeah.
Does PRP need to be done certain day of the cycle or
No.
as long as it is before embryo transfer?
No, the only problem with when you do it is if you've got a big follicle there, it makes it harder for us to get into the right part of the ovary. But no, it doesn't have to be done in a specific part of the cycle.
Here's a question for you, Dr. Victory.
Okay.
Is it true that older fathers have more daughters?
No, but IVF makes more daughters.
There you go.
Yeah. Do I suggest ICSI even without male factor? Great question, Natia. It's complicated. So all of the studies say no. And when I was in Chicago, there was a debate on this, and the debate said no as well. However, I disagree. And I asked the question in the debate, and no one wanted to answer because they didn't want to fess up to the truth. So my question was, none of this data applies if your ICSI success rates are high. If you're getting 100% fertilization like Dr. Khosravi does, then you're not going to get, any kind of value from the studies, which are all based on people who got 60 to 70% ICSI rates. So it's very hard to know. So all I can tell you is in our lab, we do ICSI for everybody. But in another lab, if they're only getting you 70%, it's probably not worth it if you don't have male factor.
I just thought that you should definitely have Dr. Khosravi on the show. As an embryologist,
that would be wild.
That would be wild.
Who's user 66010505159979? Should I be concerned? What was the other part of the question?
Yes.
No, what was her question?
There is no other question. It just showed up. Should I be concerned?
That's it?
That's it.
There's no previous question?
Just be concerned.
Oh, I don't know. I have no idea what to be concerned about. How can you bring on a period? You were given Provera. I have PCOS. If you took Provera and you didn't have a period, you're either blocked or pregnant, or you are so hyperandrogenized that even the Provera won't work. So then we would use birth control. Oh, wait, user 669. My question was, I'm waiting. Drum roll.
The pressure to type has never been greater.
Recommendation for 5 months pregnant with COVID. Tylenol. Oh, it's doing the thing. Take Tylenol, take fluids, all that stuff. How do doctors decide dual triggers versus one like Ovidrel? Smart doctors do dual trigger. Not so smart doctors don't. Here we go. I'm 3.5 months pregnant. Should I be concerned? That's still not a question. I don't know what you're concerned about. Thoughts on ERA?
Yes! Yes. This is it. We've been waiting.
Yeah, the ERA test is
I can't believe
useless.
that's what we've been waiting for.
Clinically proven to be useless, reduces your chances of success by 13%. What's a dual trigger? GnRH agonist and HCG at the same time. ERA bad. KM says ERA bad.
You know what? I'll be honest. I think everyone, because a lot of these people that are in like fertility groups and subgroups and chats, and there's like a good peer support network. I think everyone should just go out there.
Say ERA bad.
ERA bad.
ERA bad.
ERA bad.
ERA bad. That's our new logo. ERA bad.
And you know what? If you don't want to take the heat, Dr. T says.
Dr. T says. That would be a great T-shirt. Dr. T says ERA bad.
You know what? Let's make it.
Let's make that.
We
saw that one. All right, guys. It's 9:05.
9:05?
Yeah, I've got like 400 emails to answer. So we love you all. We'll let you know if we're going to have a show next week because my wife might execute me if I have a show during holidays, but we'll see. And Jenny, I hope you had a great day. And literally me being Dr. V on those TTC groups saying ERA is bad. That's hilarious. I love you, honey. I can't wait to see you. Have a safe flight home. Locked and loaded. That's my girl. And congratulations on your master's. Congratulations on med school. Thank you for being the only one of my children that comes on here and watches faithfully. That's why you're still my favorite. I love you, and I'll see you soon. Have a good